Welcome. Can you all see me on Zoom? I'm modeling this year's fleece. It has a striking resemblance to everyone's favorite fleece, but the collar's a little different. The cuffs, and we got zippers on the pockets. But I do have to say the women's fleece is different. This didn't come in women's sizes, so it's a little gray, a little more lightweight. So don't blame me. And I am also modeling the new version of the lanyard, Women in Neurology. So come up, and it's for guys too, although Joel didn't put his on yet. Yeah, so come down at the end and we'll all get our new lanyards. And thanks to Maria for the lanyards. Okay, here's today's CME Yognup. And we have applicants on the internet, so welcome. I'll be speaking to you in about an hour and a bit, but welcome to Duke. Next week's grand rounds are virtual only, not even in here. There'll be nothing in here. At first I was irritated and agitated because I'm old, but did you see the giant screens outside? That's what they're going to do next week, install the big giant plasma screens like we have in DCT here. So we won't have the old thing anymore. So that'll be nice. We'll still have the same dead roaches that have been here for 5 years, but there'll be a new TV screen. And maybe we'll get a clock up there at some point. Okay, January 14th is Martin Luther King Day. Duke is having a celebration on January 10th, where Grant Hill will be delivering the keynote address. It's at the Duke Chapel, and it will be on the website. I think it's actually January 14th. It's just Maria put January 10th there to remind me what day today was. Is that why it says January 10th?
Today is January 10th.
Okay, but this is January 15th.
Correct.
Gotcha. All right. Mirdi Luti is one of this week's All-Stars, nominated by Tasneem and River Jordan for doing an incredible job on one particular night shift, and I'm sure doing a great job on them all. So congratulations. But we have not just one All-Star today. Our next All-Star is Andrea, again nominated by the serial nominator, Dylan Ryan. Andrea did an incredible job with a stroke code due to her communication skills and excellence as a physician, and we're all proud of her, which indeed we are. Also nominated is David Fear. David's leadership and a patient who showed up completely unexpectedly, handled him beautifully. Everyone was happy, and David had that huge smile on his face. And then finally, we nominated Dylan because he nominates everyone else. We're making everyone feel special. Thank you. Okay, Maggie Soltis talked to CNN about people who have more interrupted sleep in their 30s and 40s are twice as likely to have memory problems. I have to say I slept like a baby in my 30s and 40s, and now I'm older and I can't sleep at all and have a memory problem. So I'm a little atypical for that pattern. Sneha was part of a study that looked at changing demographic characteristics in people with tremor and Parkinson's disease. Shoyan Lee and Rick Bedlack were authors of the 73rd entry into ALS Untangled, looking at a supplement called Lion's Mane. Has anyone ever heard of that? Lion's Mane? Anyone take it? No? Okay. Is it made from a lion's mane, or is that just its name? I guess we'll have to get more next week. Okay, we had a great resident report this week on Tuesday, talking about two classic neurologic conditions. One was alexia without agraphia, which was described by a particular neurologist. The other was Gerstmann syndrome, which is a bizarre syndrome that nobody understands. A particular neurologist that I knew described alexia without agraphia and was very important in popularizing Gerstmann. So that's a picture of him. Does anyone know his name? That's so sad. It's Norman Geschwind. Norman Geschwind. Okay, he died young of a heart attack at like age 54. Okay, again, today's a CME code. And today's case is, not case, but Educate the Educator, which we haven't had in a while, is our own Dr. Katie Moore. The stop share and multiple. All right, Katie, you should be able to do it.
Got it. Okay. Well, good morning, everyone. Thank you for having me today. I'm Dr. Katie Moore. I'm the Associate Program Director for the Residency and a Movement Disorder faculty member here. I've been honored to take on the leadership of our Educate the Educators initiative, which includes this series. And I hope my short presentation this morning will be helpful for you. For a lot of you, this is going to be a reminder, but I want to focus our reminder today on the impact of your work in resident feedback and assessment, and the impact that that has on both the residents and the residency leadership. So hopefully this will advance. Okay, so now, even from the Maureen Road Clinic, I can feel your sighs of dread as you see me mention feedback. And while we're going to review some effective feedback tips, I'm going to focus in these 5 minutes on why effective feedback is so important. In academic medicine, we're familiar with the three-part aim of providing and improving patient care, research, and medical education. But medical education can tend to play third wheel to the others, but I would argue that it can have just as much, if not more, impact on our future. Every single one of us who interacts with our learners has the chance to make an impact, and all of that without a lab or grant funding. So like good science and good clinical care, effective feedback requires us to be intentional, to be observant, to be inquisitive, and importantly for this talk, to report your findings. These are all skills that you already have. So how do we improve as people? Many of you may have been spending time recently considering your aspirations and goals for 2024. We sit and make lists of areas in our lives we want to improve. And I want to remind you that our residents are enthusiastic and motivated physicians who are striving to be better neurologists with us. The leadership of the residency already requires them to develop their own individualized learning plans. And just like any of us developing our own 2024 resolutions, the residents and the leadership can benefit from trusted mentors and leaders in our own journey. So basically, we need you. As iron sharpens iron, the residents need you to identify concrete and objective, as well as specific areas they can be working on. And that's why your feedback is so valuable to us. So together we can do it. So let's talk a little bit and go back to your skills in science and clinical care and how you can pivot those to giving effective feedback. So first, being intentional. Good science, good clinical care doesn't just happen. You have to be intentional and focused on these aspects of your work. And I encourage you with me to be intentional about this critical part of our three-part mission. Being observant. If you're anything like me, you've got at least 10 things on your mind at all time, and focusing your observation on trainees, whether that's their presentation, their notes, exams, interactions with others, helps us to develop better feedback. So we have to be focused on those things. Be inquisitive. It's not often clear how someone has reasoned out a problem or how someone might want to improve. Ask the residents how they arrived at a diagnosis, even if it's correct. You can learn a lot about their thinking process and how we can help this get stronger. And again, I want to emphasize, report your findings. Giving timely in-person feedback to residents can be invaluable, but just like a scientific breakthrough, you have to share your findings. Your written feedback to the residents and the leadership is critical to help us take your finding, the area of growth that you've identified, and complete the cycle of planning for changing, improving, and then reviewing. So what would reviewer 2 say about your feedback? So if you're reporting your findings, you want to get good feedback from your reviewers. We've all been there, like the comments on the left, read more, keep up the good work, accidentally just filling in a single letter. And while you're awesome and we want to have good positive feedback for the resident, it's always nice to hear you're doing a good job. Really effective feedback is more like that on the right. And this is the stuff that would get past a reviewer and not get you desk rejected. So this kind of feedback is specific, and as you'll see there, focuses on one area. It doesn't have to be comprehensive. It's timely, objective, and plan-based. So not focusing on somebody's personality, but tell them, here's some specific areas that I've noticed that you could be working on. You'll see the comments on the right, again, do not have to be comprehensive. They're specific and concrete, and the resident can take your feedback and run with it, so to speak. So with this feedback, the resident and their advisor can develop a plan to improve these areas. So say, for instance, you asked a friend or partner how you could improve like your 2024 resolutions. Perhaps you'd want something similar, something specific, timely, objective, and plan-based, not necessarily a comprehensive list of all your faults. So just like in research, you can provide effective written feedback by focusing on a specific area for improvement. So in the interest of giving Dr. Tagg all his time, I won't review this video with you, but I think it's a really interesting listen. It's about 3 minutes long, so I encourage you to click this link or use the QR code. Basically, this is a short video from the medical interns at the University of Cincinnati, and one of the things that they say is telling you to give better feedback is just like you telling us to read more. So they realize that that's not particularly helpful, and so hopefully you'll recognize some of the words on the slide that I've been emphasizing today. You want to have examples of feedback that are specific, timely, objective, and plan-based. And that's how the residents can really take what you're taking the time to write and improve their journey. So I hope you'll join me this year, 2024, in my own resolution to strive to improve my written feedback to the residents so that together we can help them be prepared to represent us well. And if you're an enthusiastic educator and want to help improve education across our department, I'd encourage you to reach out to me as we make our plan.
Thank you, Katie. I mean, I would say everyone knows that I am like the worst at giving feedback. Oh, no, don't do that. What button do I hit? Okay, shouldn't have hit that one. All right. Katie, can you hit stop share? So anyway, I'm terrible at feedback, terrible. But I once gave someone great feedback when they were a first-year neurology. This is a very prominent person who I will not mention, not at our department. This guy was so smart. He literally knew every fact. But one morning I came in and everyone was mad at him. And I said, X, a little less smart and a little more nice. And he still quotes that to this day. So that was the only time I've given anyone good feedback. But be that as it may. All right. Today's grand round speaker is, and I'm not showing any slides, by the way, so don't text me to say your slides aren't showing, is Dr. Nathan Tagg. He's an associate professor of ophthalmology and neurology at Duke. He did his MD at the University of Iowa, where it is a really incredible place. It gets very cold out there, though, at this time of year. Yeah. And then his residency in Bethesda, and then went back to Iowa for his optho. I guess you probably did the NIH thing before you went back to Iowa, or you just kept going back and forth? It's complicated. All right, you can tell us, yeah. Okay. He has a long list of leadership experience in the military, as does our department. Our department has a whole list of folks like Mark Skeen and others who've been various leadership positions. Something I've always been proud of here. Assistant professor at the National Naval Medical Center in Bethesda, battalion surgeon, chief of neurology at a U.S. Army hospital in South Korea, and then chair at the Uniformed Services University in Bethesda and chair of neurology at Walter Reed in Bethesda. All that, just bespeaks, someone with a lot of leadership abilities, and we're certainly thrilled to have him here. He has a whole series of publications, mostly centered around his patients and various diseases. And today he's going to talk to us about something I have never heard of. Has anyone in this room ever heard of this? No? All right. So then this will be really exciting. So Dr. Tagg, welcome, and it's all yours. That's not from me, by the way.
Okay. And if I hit this one,
Yep, you got to share first. Sorry,
that's
not
okay.
bad. So just go to share screen, it's down. Yep. And then zoom in on that one. Yep. Give your floating meeting controls.
Okay.
Awesome.
Perfect. Well, thank you so much for that kind introduction. I have a lot to talk about, so I'm just going to jump in. If you haven't heard of this disease, you're not alone. As we get going, you will all be familiar with the syndrome. You may not be familiar with the eponym, but that's okay. Thank you. So the key player of this talk is something called the papillomacular bundle, which I've depicted here. This is a part of the retinal nerve fiber layer. And the papillomacular bundle, which I'll refer to as the PMB, courses from the optic disc to the fovea and is made up of unmyelinated axons that serve central vision and color vision. Tap on the screen. Okay, so I'm going to present two cases. Both of these cases I've seen since I've been here. I've been here for about 2.5 years. The first case is a 47-year-old who complained of vision loss over a 6-week period. And he had both decreased color vision and decreased acuity. He also complained of pain, no pain with eye movements, but he complained of numbness in both feet, but no other neurological symptoms. And he had a history of heavy alcohol use, but was otherwise fairly healthy gentleman as far as we know. He did not visit the doctor very often. His visual acuity, as you can see here, was decreased to the 20/150 range, and he had very poor color vision. His visual fields show that he has bilateral central scotomas. And if you look at the foveal threshold here, which is a measure of central vision, it's significantly decreased in both eyes. His examination showed a little bit of hyperemia of the optic disc and maybe some telangiectatic vessels, but otherwise was fairly unremarkable, his fundoscopic examination. Now, this is an OCT. Some of you may be familiar with this, but for those of you who are not, I want to describe it a little bit because this image will come up again and again throughout the talk. An OCT, this particular OCT measures what's called the nerve fiber layer. And what it does, the machine scans in a halo around the optic disc, and then it snips that halo and transforms a circle into a line. And then it measures the nerve fiber layer and plots it on this graph here. So the black line is this patient's average nerve fiber layer in the right eye over here and the left eye over here. And in this particular case, you can see that the temporal side of the disc, which is depicted on the left of the image and also over here on the right of the image, is a little bit in the thin zone, approaching the red zone. And then there is a little bit of swelling of the superior portion of the optic disc over here as well. And that's present in both eyes. So this is important because that temporal sector of the RNFL represents that PMB, the papillomacular bundle that I talked about before. His MRI was read as negative, and I put it in quotes because you'll see that it's not entirely negative in a moment. And this syndrome of decreased vision, central scotomas, is very characteristic of somebody who has either toxic, metabolic, or inherited optic neuropathy. And so we did the workup for this optic neuropathy, and we found that he had decreased folate and elevated homocysteine, which is indicative of functional folate deficiency. And the rest of his vitamins were negative, and we did a mitochondrial genome panel as well, looking for Leber's hereditary optic neuropathy mutations, and that was also negative. Here's his MRI. This is a coronal T2, and you can see that there's fluid around the optic nerve, which there should be. The optic nerve itself looks gray, and it should be about the same shade of gray as the white matter in the brain. But you can see right in the center there is a little tiny white dot, and I believe that is the PMB that's affected by this condition, the papillomacular bundle. So not entirely normal. So here's another case. This is going to sound like deja vu all over again, but a 25-year-old man, a sudden change in vision in both eyes with progressive worsening over about 2 weeks. He had a prior history of heavy alcohol use, but had not used for some time, according to his report, and no other health problems. So his vision is much worse in the 4/200 range, which you'll just have to take my word for. That's much worse than 2100 or 2150. Although his color vision was relatively intact, he had thinning of the temporal portion of the optic disc in both eyes. Here are his visual fields, again, showing not only central scotomas, but also some superior visual field loss. And here again is an OCT that looks remarkably similar to the last OCT that we saw. So again, patient with progressive central and color vision loss, involvement of the temporal portion of the RNFL. And so we went down that whole pathway again, toxic, metabolic, inherited optic neuropathies. In his case, all of the vitamins were within the normal range. However, his homocysteine was a little bit elevated, which might have suggested a somewhat of a functional folate deficiency. His MRI was similar to the last one, but in this case, he did have a mutation for Leber's hereditary optic neuropathy. This mutation, the 11778 mutation, along with 3 other mutations, account for about 95% of patients with Leber's. And this particular mutation is, if you have to have one, it's not the one you want because it's usually associated with worse vision and a poorer prognosis. All right, so keep these cases in mind as we go along. I want to transition now and talk to you about a little bit of neurological history. This is Charles Miller Fisher, which many of you, I'm sure, know as a luminary in neurology history. He was one of the first, if not the first, to describe the role of carotid disease in stroke. He described TIAs. He described many other Lacunar syndromes, normal pressure hydrocephalus, a lot of things. Miller-Fisher variant of GBS. But before all that, he published this paper. And one of the things I didn't know about him was that he was until I researched this talk, was that he was a British naval officer. And he was aboard a vessel that was attacked by the Germans. And as the vessel was sinking, to save his life, he had to jump into the Atlantic. And he was plucked out of the Atlantic by the Germans and held prisoner for 3.5 years. And during that time, he learned to speak German, and he served as a physician for other prisoners. So he has a lot of experience. And not only was he a neurologist and a former prisoner of war, but he was also a neuropathologist. So he publishes this paper in 1955 where he discusses the residual neuropathological changes in Canadians held prisoners of war by the Japanese. And he calls this Strachan disease. So I want to talk a little bit about what his findings are. This article that he published is very, very long and detailed. I'm just going to touch on a few points here. One of the things he says about these prisoners is that their clinical picture was very uniform from camp to camp. They had disturbances consisting of peripheral edema, paresthesias in the hands and feet, the trunk, and sometimes the face. They had impaired vision and ataxia. And then they had a host of other much less common complaints that might have involved cranial nerves and cognition and such. So in 1941, after the defense of Hong Kong, almost 1,700 Canadians were taken prisoners of war. And of those, 1,415 survived. After capture, they were put in pretty horrific conditions that led to a drastic decline in their overall health. And almost all of these neurological complaints developed in early 1942, so about 3 or 4 months after they were taken captive. And again, he talks about the swelling that happens, and about the same time as the swelling, they started having paresthesias in the lower extremities, including tingling, pins and needles. And then he describes this sort of axonal and length-dependent process where it was first the distal lower extremities, and then the hands, and then sometimes the trunk and the face would also become involved. And they had worsening ataxia, and their reflexes also progressed in a way such that they were hyperreflexive, then hypo, and then they lost their reflexes. And then he talks about the vision. So about 2/3 of patients in this camp developed a vision impairment. And some of them were functionally blind. Their vision was so impaired. And many of them, in the worst cases, developed pallor of the optic disc in that temporal sector. This is a photo from Twitter, from the Canadian Military History Twitter account. And this is a photo of these prisoners within days after their liberation from this Japanese camp. And you can see that, to a man, they are completely emaciated and have gone through horrible deprivation. So I want to talk to you about one of the cases that he reported in particular. This case was the most severe of all of the cases that he evaluated, and there were 11 total. This particular soldier died at age 33. He suffered severe conditions. He became ill in late 1942, and then in November 1942, suffered severe malnutrition. And by January 1943, he was complaining of decreased vision. He was complaining of electrical shocks in the extremities, weakness in the extremities, bilateral deafness, aphonia. And so he was admitted to the camp hospital and kept there until he was repatriated in 1944. And during his stay in the hospital, he received thiamine injections as well as other vitamin supplementation. And after he passed, C. Miller Fisher and others did autopsy studies. And this is a myelin stain of the spinal cord showing that he has severe demyelination of the posterior columns in virtually every part of the spinal cord, cervical, thoracic, and lumbar as well. And he also comments that while other patients or other soldiers had this same finding, this particular one had some demyelinating features of the lateral portion of the spinal cord, not the lateral columns, the corticospinal tract, but other sort of unexpected areas of the spinal cord that were involved. And this is a slide showing the optic nerve findings. Panel A there is a normal appearing optic nerve from one of these soldiers, one of these prisoners. And panel B shows that there's demyelination and axon loss in only a section of the optic nerve. This is again from that same patient I just described. And this is showing degradation of that PMB, the papillomacular bundle. And you can see that there are similar findings on 4 of the other soldiers who were described in this study. So just to summarize his clinical data, all 11 cases had what was probably a peripheral neuropathy, mostly a sensory neuropathy. 6 of the 11 cases had decreased vision, 2 of which had severely decreased vision. And after repatriation, 4 of the 11 continue to have vision problems. A summary of his pathological findings, he found no brain changes that would be related to nutritional deficiency. 7 of the 11 had those demyelinating changes in the spinal cord, and 4 had changes to the PMB. And there was no involvement, interestingly, no involvement of the lateral columns, or the corticospinal tract. So then he concludes by saying that this constellation of signs and symptoms has been seen throughout history and many places, tropical countries in both war and peace. And so he proposes the term Strachan syndrome because it had not been given a name before. And Strachan was a medical officer in Jamaica who first described a similar condition in 1888, but attributed it incorrectly to malaria. So I'm going to skip ahead just a little bit here and talk about Henry Strachan just briefly. I went back and I couldn't find the original publication from Strachan, but I found a paper that talked about some of his findings. And so he was in Jamaica in 1888, and within about 10 years, he started seeing multiple cases of what he described as multiple neuritis. So he describes a more or less widespread neuritis that affected the sensory nerves, especially vision and the optic nerve. He described what he called trophic changes in the skin along the distribution of nerve termination in the muscles. I'm not exactly sure what that was, and that wasn't described in the cases presented by Miller Fisher. And he talks about how their rare monoplegia is also not reported by Fisher. And he also says that the recovery is the rule and fatal termination is very rare. Also a little bit different from what C. Miller Fisher had described, but nevertheless, Miller Fisher termed this Strachan's disease. And I think that it was actually called Strachan's disease for some time. So let's stay in the same time period in the late 1800s, but let's shift to another part of the West Indies in Cuba. And you all remember that Cuba was under Spanish colonial control from about the 1500s. And in 1895, there was an insurgency where Cubans wanted to kick the Spanish out. And in order to crush that insurgency, the Spanish government sent this man, and I'm not sure how to pronounce his name properly, but Valeriano Weyler. He was the Spanish colonial governor of Cuba, and he was ruthless. He was called the Butcher. And his tactic in getting rid of the insurgents was to confine a large number of Cuban peasants from the countryside into urban concentration camps, basically. And he did this to deprive the insurgents of food and shelter and other support. So then after he concentrated the peasants into these urban areas, he burned the countryside. And he did this again to wage war against the insurgents. But he didn't provide for the adequate nutrition of those that he confined in the concentration camps. And so these peasants suffered severe malnutrition and deprivation. And about the same time, the US was very interested in the Spanish influence in Cuba. And Teddy Roosevelt was the Assistant Secretary of the Navy. And the Navy sent this ship, the USS Maine, to Havana Harbor to kind of monitor the situation and to, quote unquote, protect American interests in Cuba. And Teddy Roosevelt was very much an advocate for the US being involved in this war because he felt it would set the stage for US influence throughout the world. And so when the USS Maine was bombed in 1898, there was an uprising or an outrage rather in the United States, and this triggered the Spanish-American War. Over 200 sailors were killed, and it was quite the event. So the US Navy sent far more warships to Havana Harbor to blockade. So it did not, the Spanish could not bring in supplies and food to the occupiers. And so this blockade contributed to the problem of malnutrition and deprivation to many of the Cuban population. So here's a picture of Teddy Roosevelt, who I guess wanted in on the action and stepped down from his role as Assistant Secretary of the Navy to lead the Rough Riders, but that's another story. So in that setting, this doctor, Domingo Madan, who was an ophthalmologist and had some experience in studying optic nerve disorders, he took care of many of these patients and described malnourished Cuban peasants in the late 1800s who complained of decreased vision and sensory peripheral neuropathy. And later this was termed malnutrition amblyopia. So he got it right, actually. Or maybe a little more political, it was called blockade amblyopia. So let's again pivot here a little bit, but stay in the same part of the world. So let's fast forward to Cuba in 1991. So a lot was happening in the world in 1991. The USSR collapsed. And with the collapse of the USSR, Cuba lost much of its domestic support. So they lost imports, their GDP dropped. And just as an example, petroleum imports dropped by 90%. And food imports also dropped substantially. So the average Cuban had about 20% of their prior food intake and lost up to about 20 pounds over a very short period of time. Fidel Castro called this a special period. It seemed like the world was against him. So they lost support from the USSR, and about the same time, the US had tightened the embargo against Cuba with the intent of wreaking havoc on the island. The person who actually wrote the legislation of the Cuban Democracy Act wrote that he intended to wreak havoc on that island. And it did. So around that time, this is a Washington Post article from 1993. There were reports of many Cubans who were suffering this malnutrition and other deprivation who started to have was called a baffling blindness. And it wasn't just a few patients, it was many. Just over 50,000 Cubans experienced a type of neuropathy, and it's been referred to as Cuban epidemic neuropathy. And about half of those experienced vision loss, and the other half experienced peripheral neuropathy with or without vision loss. It started in a region in the west of Cuba called Pinar del Rio, which I understand is a place where they do a lot of tobacco farming, and there's a lot of smoking. It initially affected young men with vision loss, but later men and women of all ages, with the exception of children. So what are the features? Well, similar to what we've already described, there's progressive bilateral loss of acuity and contrast sensitivity, decreased color vision, peripheral vision remains normal, and the temporal portion of the optic disc was affected. There's a tangent screen visual field from a study that was done on some of these, one of these Cuban patients showing secocentral scotomas. All right, features of the peripheral neuropathy, again, similar to what we've heard about already: numbness, paresthesias, gait imbalance. A few had dysautonomia and cranial nerve problems. And there were some nerve conduction studies that were reported on showing mostly an axonal sensory greater than motor neuropathy. So there was a very good international response to this crisis, initiated with a request from the Cuban government. So the Pan American Health Organization rounded up scientists and physicians from the US and other places to take small teams into Cuba to try to figure out what was going on. And by early 1993, there was this thought that it had something to do with the nutritional problem. And so there was a massive distribution of vitamin supplementation that happened throughout the entire island. And it seemed to work, because by September of 93, new cases stopped occurring, stopped being reported. And here's just a timeline showing what happened with both the optic neuropathy and the peripheral neuropathy. So the optic neuropathy seemed to come on first and peaked first, and then the peripheral neuropathy followed. So this is one of the participants in the American response. This is Alfredo Sadun, who is a well-known neuro-ophthalmologist at UCLA, and I believe his daughter is actually a rheumatologist here at Duke. But he was interviewed by the BBC sometime after he went into Cuba and had some insights. And I'm going to try to play an audio clip from an interview from the BBC for you to hear.
I don't know if anyone else can hear it, but I'm not hearing the audio.
It's almost over. Right. So not everybody heard that, and I'm sorry, but basically they were, for those on Zoom who didn't hear it, they were describing that when they were doing the epidemiologic investigation, they found that many of these patients had consumed bootleg rum, and bootleg rum contains a small fraction of methanol, which metabolizes to formic acid, which can be toxic to the optic nerves. And so it was thought that the Cuban epidemic neuropathy was caused by a combination of malnutrition and use of bootleg rum. And this was the initial idea that led to this push to mass distribute vitamins throughout the island. But it's not clear that that was the entire story. There was a study that was published in New England Journal of Medicine by what's been referred to as the Cuban Neuropathy Field Investigation Team. And this was in September of 1993. So this is well after the supplementation had been given and sort of at the end of the epidemic. And they did a very systematic case control study of 123 people and compared different factors. And they came up with a little bit different conclusion. So this is, just the characteristics of the 123 cases and controls. I don't want you to go over everything, but it shows that they're fairly well matched in terms of age and gender. But in terms of occupation, there were some clear differences. So if you had an agriculture-based occupation or you did not work outside the home, you were much more likely to get the neuropathy than if you had like a service job. And then if your income was lower, then you probably were more likely as well. All right, this is also really interesting. If you smoke more than 4 cigars per day, you had a 23-fold increase in the odds ratio of getting the neuropathy, and particularly the optic neuropathy. So there's very strong correlation with smoking, and particularly cigar smoking. And this is a very busy slide, but this is looking at lots of different elements in the diet, and so nutritional intake. And they found that if you consumed a certain amount of cassava, then your odds ratio of getting the neuropathy was about 3-fold. And it was thought that this was important because cassava contains cyanide, and cyanide is toxic to mitochondria, which I'll talk about a little bit later. There were some elements in the diet that were protective, and that included if your overall energy intake was higher, so you consume more food, you were somewhat protected. And if you consume B12, you were somewhat protected. So their conclusions were that the neuropathy was caused by a deterioration in diet and malnutrition, plus a high prevalence of smoking and possibly cassava consumption. And so that's sort of where it's been left. It's not really known for sure. They did look at genetic influences and were unable to find any relationship with certain genes that would predispose patients. So a few of the curious features were that children were minimally affected, and that's probably because of the practices of not allowing children to go hungry. So the rationing of food was preferential for children. But if you were a child and your parents smoked heavily, then you were a little bit more likely to get it. People who were affected lost more weight and smoked more. And then interestingly, the optic neuropathy seemed to have a little bit of a male predominance, whereas the neuropathy had a little bit of a female predominance. So in 1997, there were some Cuban, I believe these are Cuban physicians who argued that the name should be changed from Strachan disease to Strachan Madan disease. And I don't think it's stuck, but that's where the title of the talk comes from. I wanted to share with you another case. This is another patient that I saw while here, and some of you may be familiar with this case. She was admitted to the inpatient service here. So a 56-year-old woman referred for decreased vision ongoing for about 6 months. Initially, it was felt that her cataracts were the culprit, and so she underwent cataract surgery, which did not help. And then she started having problems walking, which was initially slowly progressive, but then fairly rapidly progressive. She also complained of slurred speech, imbalance, weight loss, and had a history of heavy alcohol and smoking use. She had been diagnosed with B12 deficiency and was given oral supplementation. So on our examination, her acuity was down around the 2200, 2300 range. Her color vision was down and she had temporal pallor. So hopefully by now I've convinced you that if you see temporal pallor of the optic disc, you should be thinking about, and it's symmetric, you should be thinking about toxic, metabolic, and nutritional and inherited optic neuropathies. And that papillomacular bundle is involved. So to continue her exam, and this was done in the eye clinic, she had relatively preserved strength. So 5 out of 5 in the uppers, a little bit decreased in the lowers. She had significantly decreased sensation to all modalities from about the mid-thigh down, including, excuse me, really profound decrease in proprioception and vibration. Her reflexes were decreased and the plantar response was mute. She did have also a significant sensory ataxia in the upper and lower extremities and a little bit of truncal ataxia as well. So these are visual fields. They're not entirely reliable, but the important feature here is that there is a significant decrease of central vision. An OCT, which looks very remarkable and very similar to the prior ones where we see thinning of the temporal portion of the nerve fiber layer. And then she was admitted to work up this ataxia. And this is what to show. This is a really remarkable MRI showing that she has T2 hyperintensities in the posterior column that really runs the entire length of the spinal cord, all the way from the upper cervical cord down into the lumbar region. You can see here the same finding on the T-spine sagittal. So it was felt that this represented most likely severe B12 deficiency. And even though she was on oral supplementation, she still had the laboratory evidence of B12 deficiency with elevated homocysteine and MMA. She underwent an extensive workup for other causes that was negative. So she began B12 injections, and I actually did see her in follow-up not long after. She had not improved that much with respect to her vision, but her gait had improved a little. Right, so let me just go over a few of the findings just to review. So the normal OCT is here on the left, excuse me. And you can see that this profile, this black line of the retinal nerve fiber layer thickness is entirely within the green zone in both eyes. This is a typical OCT of somebody with PMB involvement, so thinning of the temporal section. This is a map of ganglion cells. So cell bodies within the retina in the perifoveal area. And the heat map should look like this, these images on the left where there's a donut. Now the color is a little bit different, but the important feature here on the right is when you have a thin ganglion cell layer, you don't have that donut. You just sort of have a flat heat map. So that's what you see. On fundus examination, you can see pallor of the temporal sector of the optic disc. And you can actually see the nerve fiber layer here, this white sheen, superiorly and inferiorly. And there's this demarcation line right about here. Hopefully everybody can see the mouse that shows that there's a dramatic dropout of nerve fiber layer across that line. So this is normal on this side. Excuse me, the whitish sheen is normal. And then that sheen drops off as you get closer to the macula, right? There was at least one of these patients from the Cuban optic neuropathy group that had an OCT when it became available. Now, OCT was not available, it was not around in 91 or 93, but many years later, like in the early to mid 2000s, these patients were studied. And you can see here, this is a first generation OCT, but you can see that that RNFL is thin, and it's thin in both eyes. So just adding support for this being a symmetric process. And then this is a fundus photo of one of those patients showing temporal pallor as well. All right, so to compare The nutritional optic neuropathy has some features in common with the inherited optic neuropathy. Now, the etiology, of course, is different. One is a genetic mutation, and another is from B12, folate, or B1 deficiency. Age of onset, though, can be any age. In Leber's disease, the optic neuropathy is usually sudden in onset. It's usually unilateral. So the case I presented before, where it was bilateral, was a little bit atypical, but it can occur. Usually those patients are in their 20s and 30s and are a little bit younger, but it has been reported in any age. And then, of course, nutritional deficiency doesn't respect age. The symptoms are the same in terms of the type of vision loss. They have bilateral central scotomas, loss of color vision, loss of acuity, and late findings of temporal pallor. You can have a little bit of swelling early on in Leber's disease, but that's not a not a common feature in nutritional disease. Some patients with Leber's can have spontaneous improvement. It is incomplete, so they have persistent vision loss. And then, of course, with the vitamin deficiencies, if you get to them soon enough, you can prevent further vision loss, and they can have some improvement. But if you don't, if they have atrophy of the optic nerves, they will not improve despite repletion of that vitamin. And then the papillomacular bundle is the real estate of interest in both conditions. And then this is, I'm not going to go over everything here, but this is another slide just showing that nutritional neuropathies are very much like toxic neuropathies, and the toxins include like methanol and ethambutol and others. This is a very busy slide, but I think I'm going to go through it a little bit because I think it's important in terms of the pathophysiology. This was recently published by that same doctor who went to Cuba, Alfredo Sadun. And this is a schema showing the idea, or at least a theory about what happens in Leber's disease. So we know that Leber's disease is a disease that affects the mitochondria, and specifically oxidative phosphorylation. Complex 1 in that electron transport chain is the complex of interest. And it's thought that in Leber's disease, coenzyme Q10 does not dock properly in its normal binding site. And so it's been sort of likened to a clog in the drain. So as electrons are transported down that chain, they cannot make it past this blockade of the CoQ10. And so electrons spill over and create reactive oxygen species. And those reactive oxygen species induce apoptosis in ganglion cells, retinal ganglion cells, which I think is a unique feature of retinal ganglion cells. And so here's an old slide just showing how like B12 and cyanide and folic acid and Leber's mutations can influence oxidative phosphorylation. I'm not going to go into it in a great amount of detail because I don't entirely understand it, but just know that it's thought that B12 is somehow directly related to oxidative phosphorylation. And when there's a deficiency in B12, it might be that cyanide increases, and cyanide is toxic to mitochondria. So one question that I think is really important is, why does the PMB become affected preferentially? Excuse me. And I don't think we entirely know the reason for that, but one hypothesis is that mitochondria are concentrated at the nodes of Ranvier in myelinated axons. And of course, within the eye, the retinal nerve fiber layer is unmyelinated, and they're packed full of mitochondria to help with trophic support of the nerve fiber layer. And especially in the PMB, which is an area that is highly metabolically active, those fibers are very, very thin. And so there's probably a higher concentration of mitochondria. So it's thought that when these reactive oxygen species induce apoptosis, they do so preferentially to the PMB because there's so many mitochondria within the PMB. All right, so to conclude, we have many historical examples of toxic metabolic and nutritional optic neuropathy. Strachan Madan disease is an archaic eponym referring to the neuropathy that happens in the setting of malnutrition, deprivation, and toxicity. It's not really used today as an eponym, but please don't forget about it, because We see the effects of these nutritional and toxic conditions today in our modern world. And finally, toxic metabolic nutritional optic neuropathy resembles the phenotype of genetic mitochondrial neuropathies, and they probably share a final common pathway. So that's my talk. I appreciate your attention, and I'm happy to entertain any questions.
Thank you very much. And I would also remind folks that Will wrote a piece on Wayne Massey several years back. Wayne was also in the Navy, and during the Vietnam War described a toxic neuropathy that was due to, in a time of people had no oil in which to cook their food, started using helicopter oil to cook their food, and it contained a contaminant in it. Not a contaminant, it contained an ingredient in it that led to a peripheral neuropathy. I asked Will to send that out again, just to remind you of what great faculty members we have. So anyway, questions for Dr. Tagg from the room or the internet? We'll look at the chat. The room? Any room questions?
So do extra vitamins help the patients with Leber's at all? Or? That has not been studied, but in terms of vitamin B12, but there is a theory that excessive B12 could be helpful, but it has not been studied. The one thing that has been studied is Adebino. So this is a supplement that you can get that is available over the counter. And so there are some studies that show that there is probably a benefit to Adebino in patients.
As a brief update, thank you, Don. Don says that it was actually Marvin, not Wayne. And Dylan is shaking his head. I knew it. I knew it. All right. Anyway, I'm sure Wayne did something equally fabulous. Congratulations to both of them.
Was there another hand that went up?
If you supplement
in like B12 and folate deficiency. Well, so if you can catch them, the question is, if you supplement B12 and folate deficiency, do they recover? And I think the answer to that is it depends on when you get to them. And so if you get to them by the time that they've had atrophy of that PMB and the RNFL is very thin, my experience has been there's not a lot of vision recovery. But if you get to them, as the nerve is thinning, it hasn't really thinned too much, then they can have some improvement.
I have a question. I asked Chris this question once. Given that testing for Leber's is, 100% correct, shouldn't we just do it on everybody who shows up with any optic nerve problem? I mean, considering we get an MRI on, or 5 of them on every patient admitted to stroke, why shouldn't we do a Leber's genetic screen for anyone with an optic nerve issue?
So it's a good question. And I think there are a couple of answers. One is that it has to fit the right phenotype. So if somebody comes in with, peripheral field loss and it's asymmetric, that's not going to be.
But we're neurologists, we're not that subtle. We would just say vision loss, get a Leber's.
Well, that's why you consult neuro-ophthalmology. And then the second thing is the spectrum of mutations that can cause Leber's is actually expanding. And so we know that not every case of Leber's is actually a mitochondrial genome problem. So there are some nuclear genes that can cause Leber's.
But not everything is just one thing, but it often is that one thing. So why wouldn't you just get that test? I mean, we get B12s, ACE levels, SED rates on everybody. So this is a little more expensive, but it's also 100% accurate for its particular mutation.
So the other thing is that not everybody who has the mutation develops the syndrome. And so if you have somebody with optic neuritis and you do a Leber's test on them and it comes back positive, that's probably not relevant.
It's at least a publication.
It could be a publication. Yeah. Okay. Any other questions?
I will continue to argue about that. When I was your age, the residence age, we didn't know about mitochondrial disorders back then. It was like autoimmune autoimmune encephalitis. We didn't know. We knew people had these strange things, but we had no idea what it was due to. So again, for the young folks, I like to think what they're doing now, they have no idea what it is. In 20 years, they're going to, take it for granted they know what it is. What do you say about our residents in ophthalmoscopy? I mean, you have these pictures with retina, but we've got these handheld things that give you half a millisecond of clouded vision of an eye. So what do you recommend to us as an approach to looking at retinas and optic nerves?
Well, I think I'm a little bit old school, and I would definitely encourage the residents to learn that skill. It is a dying art. And especially during COVID, I think there was some encouragement not to get real close to the patient and look in their eye, but it's valuable. So
you recommend dilating eyes?
If possible, but there are some other techniques that you can do that I'd be happy to show anybody. You can do to get a very good look in the back of the eye without dilating. And then the other thing is that there are now these handheld cameras that can take a very good photo of the back of the eye without dilation.
We have that in clinic, but we're fighting through the bureaucracy. What are the tricks to see it at the bedside without dilation?
Well, so one technique that I really like is to use just a lens, a 20 diopter lens, and the direct ophthalmoscope. So you're not really up close to the patient. You use this lens and you can get a very good view, even through a very small pupil. So it takes an investment. You have to buy a lens, and it takes a little practice to do. But
so you have the lens and your ophthalmoscope?
Yes.
So you look.
Yeah, exactly. And our PGY2 resident who was with me on rotation tried it. And do you have any testimonials about its benefit?
It works great, especially if you have very, very tiny pupils that otherwise you would have to dilate.
How much does
Yeah.
it cost?
20 diopter lens you could probably get for a nice one would be a couple $100, but you can easily get a decent lens for under $100.
Well, that's helpful. Whoa.
So I think it's definitely worthwhile, especially if you're seeing a lot of patients with headache and where the
We do. Lot of
fundus
patients
examination is very important.
That's really useful.
Okay.
Anything on the Zoom? Yep, next week's Grand Rounds is virtual. And all right, great. Thank you, everybody. Thank you very much.
Yeah.